What is a true statement about abscess? In fact, all of them are true statements. Infective endocarditis, can it undergo embolism and lead to microabscess? Yes. Most common way of spread of an abscess is hematogenously, and always the site will decide the type of drainage you want to do, and if it is a breast abscess anywhere need to be drained pari passu along with antibiotics is what you need to basically remember. What is the common location for angiodysplasia? So it is ascending colon and cecum are the classical locations is what you need to remember. Hirschsprung's disease is another very classical topic. So Hirschsprung में क्या होता? Orbac plexus, typically ganglion cells are absent, and acetylcholine esterase become increased in those areas. More acetylcholine esterase means acetylcholine get broken down. Unless acetylcholine is there, peristalsis doesn't occur, and if peristalsis is not there, eperistalsis will be there. That's what typically will happen. And that aganglionic segment is the one which is constricted, and ganglionic segment is the one where all that obstructed food will lead to dilatation. So aganglionic is constricted, ganglionic is dilated, is what need to be remembered. And if this kind of things, you should not do reasoning in exam hall. If you do know, opposite reason only will come in the exam hall. Then there is a delayed passage of the meconium in the neonatal period is what need to be basically remembered. The other day one of our students asked, achalasia cardia versus gastric, esophageal malignancy. What is the difference? Achalasia cardia is a neuromuscular dysfunction. Both solids and liquids there will be dysphagia. Patient will say, both of them will be affected if it is achalasia, neuromuscular dysfunction. But solids initially, later on when obstruction become more severe even for liquids, then that becomes the malignancy or any organic obstruction. That is what you need to be clear. No second thought or confusion in exam hall, straight go with that. Then doctor, Hirschsprung's is associated with the aganglionic segment which is basically contracted. Coming to the hemorrhoids, basically we classify the internal hemorrhoid into various grades based on the amount of prolapse. That's a true statement. All the other are basically wrong statements. Hemorrhoids arterial dilatation nahi hota hai, venous hota hai dilatations. Then it was a misconception that they are seen in portal hypertension. Hemorrhoids, no, later on that concept has been refuted, and they said portal hypertension is an incidental finding but not a causative factor is what you have to basically remember. So what are various grades? Suppose that the hemorrhoids bleed and may protrude into but do not prolapse out of the anal canal, you call grade 1, and they prolapse only on defecation but reduce spontaneously become 2, and hemorrhoids that require manual reduction become 3, and which cannot be reduced become grade 4, as all of you know very well. Right, doctor? Now, fibrocystic disease of the breast. So basically it is more common in the age group of 35 to 45, and is it a risk factor? A good number of times your patients come because that is the same age where self-breast examination is being preached religiously, that everybody should examine before the mirror within 7 days of the menstruation, etc. But it is not pre-malignant. Fibrocystic disease is not pre-malignant is what need to be basically remembered. A good number of times if there is any hormonal therapy, because that is also the time 35 to 45 is the time where a couple of children are born, husband will say no, don't get a tubectomy done because I can't see you dying. Who will take care of my both children? And she says, get a vasectomy done. He says that no, vasectomy lead to impotence, blah, blah, blah. Google is saying he will tell. And he is afraid for going for vasectomy. Unless you explain him that there is no impotence due to that, nor his wife will not suffer a anesthetic cardiac arrest due to a simple tubectomy, unless you convince them, they don't. So they will go for adopting for a OCPs. So a middle-aged female taking OCPs, developing a cystic lesion in the breast which is painful, especially in relation to menses. So classical history, it is not pre-malignant. Just you need to tell, stop the OCPs, and obviously the cystic disease also will resolve. Now doctor, post-splenectomy is a very, very important topic. There is a video break for Manasa, Raghav and Padma. Is it same problem for our other friends, or you want to reset? It's okay. Shaj is saying it is okay means it should be okay. Just they need to restart their browser because we took a backup. Then post-splenectomy, doctor, pneumococcal vaccination is indicated, and you need to give a malaria protection. Hinge bodies are seen in RBC because normally spleen is the one which will prevent the appearance of the hinge bodies, which are the remnants of the remnants after destruction of the nucleus. Now doctor, before the age of 5 years, if you happen to do the splenectomy, you need to give the penicillin prophylaxis until the age of 10 years. Similarly, older children ko splenectomy kare to prophylaxis should be given until the age of 16. But in adults, do you need to give the penicillin prophylaxis regularly to save against the capsulated organism infection? It is not well defined. Now doctor, regarding acute peritonitis, let us talk about it. Pain is initially located on the area of inflammation. Peritonitis may, right? And the patient prefers to lie still, unlike a stone patient. Real stone patient will be rocking on the bed, but a peritonitis patient will be lying, praying God for a good villa in heaven, east facing, in a 400 square yards. Can I get one nice villa? He'll be praying, right? So then ultrasound will be diagnostic, is what you need to basically remember in case of peritonitis. He won't be tossing in bed, the pain won't be colicky in nature. Now doctor, why enteric fever may? Peritonitis is more likely to occur. Is a very, very important logic you need to basically understand. Whenever intestine suffers perforation, what will basically happen? The mesentery, which is overlying, will basically seal it and prevent the spilling of the contents into the peritoneum. How will mesentery know that oh intestine में यहाँ perforation हो गया बोल के कैसे मालूम होगा? Because even the senior MS final year surgeon also don't know where is the perforation. Unlike a GIT surgery means it is like your tire repairing shop only, no? Put in water, bubbles will come. Oh यहाँ perforation है, एक लगाओ, 2-3 पट्टी लगाए इसलिए एक पट्टी को 1000 रुपए है. तो how will mesentery know that? Basically, whenever there is a perforation, there is a localized ileus of that segment of the gut. The movements of the mesentery are actually due to the underlying movement of the gut. So the remaining part of the gut is having peristalsis and mesentery is moving. only that part of the mesentery which is overlying this due to that localized ileus will not move, and hence it will patch it. That is how whenever perforation occurs, there is a mesenteric natural patching which will occur and prevent spilling. But enteric fever mein kya hota? There is no such development of a localized ileus. So mesentery doesn't know where is the perforation, and hence peritonitis is more likely to occur whenever enteric fever perforation is there, is what you have to basically remember. Now doctor, obstetrics gynecology, let us see whether you can score 30 out of 30 marks or not at this point. Turner syndrome, easy question. It's a easy. मिलेगा या नहीं मिलेगा? नहीं मिलेगा. तो karyotype is X4. Underdeveloped uterus will be there, and primary amenorrhea will be there, and infantile nipples will be there, because there is no onset of puberty because of gonadal dysgenesis. So secondary sexual characters will be abnormal, and also shield like chest with non-development of breast is a feature of Turner syndrome, is what need to be remembered. Huh? What else? Karyotype is okay. 46 are autisms. 45x4. Okay, we'll change the number. Huh? Right. Then for termination of pregnancy, you see recent Jipper also, what was the question? Which congenital heart disease is tolerable one, which is intolerable one? PDA, tolerable or intolerable? A PDA female can carry on pregnancy. Epstein's anomaly, tolerable. But Eisenmenger syndrome, intolerable. That's what you need to basically remember. Coarctation of aorta, intolerable. So what are tolerable, intolerable lesions? You must be quite sure. Similarly, whenever there is any NEHA classification grade 4, grade 4 means बैठने पर भी अगर dyspnea है तो dyspnea at rest become grade 4. Such a woman, where will she go ahead with pregnancy? Pregnancy itself is a dyspneic state. So on the top of it, already dyspnea at rest is there. So that is also intolerable state, is what need to be basically remembered. Coming to the max sulfate usage. What is the therapeutic level, doctor? 4 to 7 is right. And you can use for seizure prophylaxis. But what is the effect of magnesium on neuromuscular blockade caused by muscle relaxants? Just like aminoglycosides, it will delay the neuromuscular blockade, is what you need to basically remember. Then just close that door, smoke is coming. Now, HIV transmission from the mother to the child, how can you basically prevent it? Simple question, no? Antiretroviral de do. There is an easy way to prevent. Breastfeeding, elective LSCS, anything can basically predispose. Then abnormal uterine bleeding. What are the various definitions is the question of the examiner. Any blood loss more than 80 milliliters become abnormal. Any duration more than 35 days or less than 21 days become abnormal. And bleeding lasting more than 7 days is abnormal, and any irregular bleeding, intermenstrual bleeding, they are also considered to be abnormal. So polymenorrhea, oligomenorrhea, what are the definitions? You must be very sure. Poly means if at all at intervals less than 3 weeks, if the bleeding episodes are happening, poly. More than 35 days it is taking for the cycle length, that become oligo. And at irregular intervals between menstrual periods you call metorrhagia. And menorrhagia means heavy bleeding, as all of you know very well. Then doctor, pelvic inflammatory disease बोलने के लिए minimum criteria क्या होता है? You may know pelvic inflammatory disease, but you may not know what are the minimum criteria as defined by the ACOG, American College of Obstetricians and Gynecologists. Cervical motion tenderness. What is meant by chandelier sign? Whenever pelvic inflammatory disease is there, cervix becomes so tender. If you happen to do cervical motion on pervaginal examination, patient will jump and catch the chandelier, hence called chandelier sign. So, one of the frequently asked question, chandelier sign is found in PID. So, cervical motion tenderness, uterine tenderness, head neck cell tenderness, they are all called minimal criteria, is what you need to basically remember. Then, if you use some other criteria, specificity badega, diagnosis mein. What are they? If the temperature is more than 101 Fahrenheit, if there is any mucopurulent discharge, and similarly there are lot of blood cells on saline microscopy of the vaginal fluid, or if ESR elevated, C-reactive protein elevated, or if there is any gonorrhea or chlamydia documented, they will increase the specificity of pelvic inflammatory disease is what I want to underscore to all of you. Now, you shoot a quick answer for this, doctor. Most important investigation for the ectopic pregnancy क्या होता है? Huh? Any day TB ultrasound, transvaginal ultrasound. So, transvaginal ultrasound can detect the gestational sac 1 week earlier than the transabdominal probe, and you can detect transvaginal using transvaginal ultrasound 14 days after the pregnancy detection by using serum HCG. उससे 14 days में you can identify it through transvaginal ultrasound. Transabdominal ultrasound अगर इस्तेमाल करें तो HCG should reach 1800 units for the gestational sac to appear. Even at 1500 units only, you can identify using transvaginal ultrasound. This is what I want to underscore to all of you. Symmetrical versus asymmetrical IUGR is a favorite question of the examiner, doctor. So tomorrow when you go for exam, when this question comes, point to point you must be ready. What examiner wants is 5 points in this topic. Between the two, which is more common? Asymmetrical is more common than symmetrical. Then in asymmetrical में क्या होता है? There is a restriction of the weight followed by the length, and the head continues to grow at normal or near normal rate. So head sparing will be there. Will head will be involved or not is a common question in IUGR. No sir, brain is not involved, head is not involved. If brain would have been involved, lot of IUGR babies would have not entered medical college. They entered medical college, they topped entrances. Ultimately, normal Taram babies were found lagging. So, a lack of subcutaneous fat will lead to the thin and small body which is out of proportion with the head in case of asymmetrical IUGR. And why will asymmetrical IUGR occur? First 2 trimesters में मतलब anatomy, physio, biochemistry, well, good marks. Microbiology, pharmacology, pathology, forensic, excellent marks. Medicine first year posting, fell in love. Last academics found duets more audible than the heart sounds. So completely clean bowled. Then housemanship आ गया, dumped in romance. So that is an example of what? Head has grown well. मतलब anatomy, physiology, biochemistry, pharmacology का basics अच्छा है. तो कहाँ चले गए? आंख में क्या है, नाक में क्या है, कान में क्या है, वो सब चले गए. Because that was all the time where there was a high romance running on. तो ENT ऑप्टल. So अभी उसको खत्म करें तो revision सीट आएगा. So that is asymmetrical, and the baby is at increased risk of hypoxia, hypoglycemia. And generally it is the extrinsic factors which are important the defect, and they typically happen during the later part of the gestational age in the final year MBBS, that lead to asymmetrical IUGR is what need to be remembered, and asymmetrical IUGR is more common. First year MBBS only falling in love means that fellow must have finished a good number of affairs in the intermediate only. Plus 2, 10th class, 8th class, 9th class only he started proposing, so intermediate first year mein aake medical college first year mein se shuru kar diya account. So that becomes what? Symmetrical IUGR. Anatomy bhi nahi pade, medicine bhi nahi pada. That becomes. Then what are the specific causes which are called extrinsic factors, which are outside the fetus, which occur in the last trimester, which lead to asymmetrical IUGR? If there is a high BP in the mother, if the mother is not eating food, severe malnutrition, and Ehlers-Danlos is the other important scenario, then symmetrical IUGR. It is only 20 to 25%, and it has developed slowly throughout the duration of pregnancy, and it started affecting in the very early stage, becomes symmetrical, and the head circumference is also decreased, body also decreased, so body and head are in similarly reduced in size, so hence called symmetrical. Then most of the neurons develop by 18th week of gestation. That's the reason if you look at symmetrical IUGR, they are more likely to have a neurological sequelae, unlike the asymmetrical IUGR where first 2 trimesters they are normal, no? So brain already developed, so no chance of brain damage there, so head is spared in case of asymmetrical IUGR. So what are the common causes? Early intrauterine infections like CMV, rubella, toxoplasmosis, chromosomal abnormalities, anemia, and any maternal substance abuse, they are the ones which are responsible. One question will come definitely in the next entrance on symmetrical, asymmetrical IUGR, and you are the only ones who are going to do correctly across the country. Now doctor, LH search, typically it can occur 12 to 24 hours. So it can occur before 12 hours or it can occur before 24 hours, and the LH will peak around 24 to 38 hours before ovulation is another value. Now, what is androgen insensitivity syndrome? They have a karyotype of XY, actually they are males. They have a testis which is intra-abdominal or sometimes in the inguinal canal as an inguinal hernia. And their testosterone cannot act on the receptors. So that is the reason they don't develop male features or descent of testis. And because testosterone production is normal, all the testosterone convert into estrogen, and any estrogen will lead to the development of the breast, is what you need to basically remember. So that's the reason the genotype is 46 XY, and there is a scanty pubic hair because testosterone is important for pubic and inguinal pubic and axillary hair. Then they have a female external genitalia, breast development is adequate, and no, not a female external genitalia, only female breast. External genitalia are not well developed. They have a blind ending pouch like vagina. That's the only thing they are mistaken for females. Then doctor, diabetes in pregnancy. If you go through the list of topics given to you, 5th or 6th topic in the list is pregnancy in a diabetic mother. Times immemorial, top 10 topics mein hota hai diabetes and pregnancy. So you can't ignore. So basically what will it lead to? Macrosomia, shoulder dystocia, hyperglycemia, hypoglycemia because of the maternal hyperglycemia, leading to fetal hyperglycemia, leading to fetal hyperinsulinemia, leading to hypoglycemia, IUGR, caudal regression, etc., etc., hypomagnesemia, polycythemia, hyperbilirubinemia. They are all the complications in the baby. Where will you put tension-free vaginal tape? If there is a stress urinary incontinence is a very, very important question, doctor. So typically, middle part of the urethra is the classical location where you will put proline tape, tension-free vaginal tape is the one is being put in the middle part of the urethra is the classical location is what you have to basically appreciate. Then doctor, second trimester ultrasound. This is repeated so frequently. Recent Jipper also, they asked anomaly scan to detect anomalies. Right doctor? See, pregnancy is like PG entrance. Why? पहला notification आना, second आप जो पढ़े वो क्वेश्चंस आना, उसके बाद आपके फ्रेंड्स नहीं आंसर करना, आप ही आंसर करना, उसके बाद काउंसलिंग में आपका फेवरेट ब्रांच, आपके फेवरेट मेडिकल कॉलेज, आपके फेवरेट प्रोफेसर के साथ मिलना. एवरीथिंग इज सब्जेक्ट टू अवेलेबिलिटी. So, pregnancy also, HCG positive, it should double properly, gestational ring should appear. वो appear होने के बाद उसमें fetal cardiac activity होना, उसके लिए एक और एक अल्ट्रासाउंड करते, उसके बाद there should not be any anomalies, right? So, if you do ultrasound, you should not find the fetus studying horizon in the womb. Arey, itna intelligent baby, I don't want, you have to pray God. So, when he is born, he should cry. He should not start telling. 10th topic of high yielding topic list, did you read mama? Your exam is day after tomorrow. So, utna intelligent also very difficult to handle. So, second trimester ultrasound kyun karte? Typically it is done between 5th and 12th week in early pregnancy scan, which is called fetal viability scan. And you need to get the heart beating, it should be reassuring. Number of fetuses bhi malum padega. You will know the intrauterine pregnancy or is it ectopic, you will know. You will know any structural abnormalities like anencephaly. So the various parameters that you will basically measure when you do the scan. Coming to PSGN, generally post-abdominal nephritis may there is no indication for renal biopsy. But there are some specific scenarios where you will do the renal biopsy in case of post-abdominal nephritis. Examiner is very particular whether you know them or not. When the renal function is impaired beyond 10 days, 10 days के बाद creatinine, urea, everything should normalize in PSGN. नहीं हुआ. Serum C3 is initially depressed because it is an immune complex deposition in PSGN. But it is supposed to normalize by 6th to 8th week. If it didn't normalize, then you should think some other diagnosis and do renal biopsy. And suppose if the azotemia is present beyond 7 to 10 days, or if there is any hypertension or gross hematuria beyond 2 to 3 weeks, or those who are having systemic features, maybe it is lupus with hematuria. Lupus can occur even in pediatric population. Pediatric lupus can occur 8-year-old, 7-year-old, 6-year-old में हो सकता है. उसमें भी when lupus is there, it lead to diffuse proliferative glomerulonephritis, which lead to hematuria. So you should always suspect if there is systemic illness. PSGN में you don't expect systemic illness. So if systemic illness is there, think of any lupus, and that becomes an indication for biopsy. Renal biopsy is what need to be remembered. Coming to scurvy, what are the important features in scurvy? There will be bleeding gums, there will be tibial edema, pseudoparalysis it is called. Typically there will be perifollicular hemorrhages and also periosteal bleed will be there. Because of that, the baby feels difficult to move his limbs, very painful it will be, periosteally bleed will be there. So he won't move, hence called pseudoparalysis is what you expect. Whereas the remaining features, wind swept deformity, splaying and cupping of metaphyses, they are all the features of what? Rickets. Scurvy का radiology, rickets का radiology. आज घर जाते ही एक बार रिविजन करना. किस में होता है Wimberger sign, किस में होता है widening of the metaphysis, etc. Everything. So this is called wind swept deformity. As such, wind has swept and led to development of a deformity. Sometimes it occurs in both the limbs. It can occur in rickets, It can also occur in case of cerebral palsy also, it can very much be seen. Coming to the IV magnesium in children, what are the important uses of it? When there is a carpopedal spasm in calcium deficiency, though calcium is a divalent cation, magnesium also, so we use magnesium. Vitamin D resistant, Torsidis depointus is another important indication, or whenever there is any hypomagnesemia. They are the classical indications, especially don't forget, favorite MCQ, Torsidis depointus, long QT. When will you call long QT? When the corrected QT interval is more than 0.40 is normal QTC. More than 120 is less than normal. 420 milliseconds is normal. More than 600 milliseconds is called long QT, and that is a predisposing factor for polymorphic VT, which is called as Torsidis. Torsidis में treatment होता है. The administration of the magnesium is what need to be remembered. Now, doctor, developmental milestones, definitely standard question in pediatrics. I'll come, I think that is the next question. So this is on obesity. How do you use BMI as a measure of obesity? BMI more than 95% is obesity, more than 85% is called overweight, and BMI is basically weight in kgs by height in meters square, as all of you know very well. Then underweight, normal weight, overweight, class 1, class 2, class 3. सबको obesity बोलते हैं अगर 30 के बाद, मगर 30 to 35, class 1, 35 to 39, class 2, like first AC compartments in AP Express. So autism is one of the favorite area of the examiner, doctor. Tare Zami pe. So is it more common in girls or boys? Because you can remember in the movie Boy only, no? Then concordance in monozygotic twins is 60 to 90. That is very difficult to guess. बहुत चीजों क्यों concordance है, कहाँ याद रखेगा? Very difficult. But child may have mental retardation is true. That's a possibility. And there is nothing like MMR increases the risk. So autism, what is the typical age where it will develop, doctor? It will develop before 3 years. And lot of times it is diagnosed by 18 months of age is what you need to basically remember. Bacterial meningitis hai. Are there any factors that suggest that there is a poor prognosis? Yes sir. Bacterial meningitis may, agar focal neurological deficits developed, like paralysis, seizures, you develop poor prognosis. And any age less than 6 months, poor prognosis. High concentration of bacteria, poor prognosis. But neck rigidity is not included in the poor prognostic findings is what you need to basically understand. Coming to hypercalcemia. Here you must know what is meant by Wolfram syndrome basically. Wolfram is also called DID mode. Diabetes insipidus, diabetes mellitus, optic atrophy, deafness. The combination is called as the Wolfram syndrome is what you need to basically remember. And in this what do you have, doctor? Do you have hypercalcemia? No, you don't have. Then hypervitaminosis C also you don't have. But hypervitaminosis D, hypervitaminosis A and Williams syndrome and thiazides will retain calcium. Loop diuretics lose calcium. So there is a reason thiazide diuretic istemal kare to bhi there is a development of hypercalcemia is what need to be remembered. What leads to the development of constipation in the case of the children is a very, very important question. So basically, any orbac plexus में गड़बड़ हो गया है तो, जैसे हिरस्प्रंग में, lot of scenarios you don't find an organic cause. Constipation is a normal finding, right? So, but lot of times parents worry. One day motion didn't pass means they will be completely panicked. Then hypothyroidism is a predisposing factor. What is milk of magnesia? Milk of magnesia is used as a laxative, Hence it leads to diarrhea, not constipation. So what did you understand? How will you get seat in PGI? If you study at least classification of water laxatives, water antidiarrheals, most ignored, purged out topic in pharmacology, which you have to read. Tetralogy of Fallot में क्या होता है? Right to left shunt होता है. And there is a pulmonic valve stenosis. And there is a overriding aorta. Hence there is a tendency for right ventricular blood to directly pass into that overriding aorta. And how is the VSD in it? VSD is not a small one, it is a large one. So that is the reason जो भी systolic murmur आपको सुनाई देता ना, वो VSD के वजह से नहीं होता. Whenever VSD is big, the pressure gradient between the two sides of the ventricular septum are more or less equal. When gradient is not there, high flow कहाँ होता नहीं होता. तो इसलिए murmur is a low murmur. So जो भी murmur आपको सुनाई दे रहे हैं systolic murmur in top, it is due to pulmonic stenosis, not due to VSD. Examiner will ask you in MD exam. देखो बेटा रामू, आपको सिस्टोलिक मर्मर सुनाई दे रहे हैं ना, ये टॉप का केस है, किसकी वजह से है? बाय मिस्टेक यू सेड VSD. 6 महीने हो जाएगा राम का अरण्यवास. तो इट इज ड्यू टू व्हाट? PS. What decides the prognosis in top out of all these lesions? It is the PS. Once more, PS is the most important deciding factor for the ultimate prognosis. More severe the PS, more bad it is. Acute tracheitis in children. What is it? Because of Staphylococcus aureus. What lead to development of neonatal cholestasis? So basically, extrahepatic biliary atresia, Allegany syndrome, Gilbert, not Gilbert, Rotor, Gotcher in all these scenarios. So what is Allegany syndrome? It is also called anterior hepatic dysplasia. It is the most common syndrome associated with intrahepatic bile duct paucity is what you need to basically remember. So all this will lead to the development of cholestasis is what you need to basically remember. Coming to the unconjugated hyperbilirubinemia, what are the important factors which you need to basically remember, doctor? Gilbert is the one. Crickland answer में there is a deficiency of glucuronyl transferase. There is a reason it will also lead to development of a unconjugated hyperbilirubinemia is what you need to remember. Developmental milestones is the favorite topic of the examiner. Without that there is no question paper. 4 months he can recognize the mother, which is true. 6 months he can make a cross. 2 years he can speak a sentence of 2 to 3 words. Tower of 3 blocks 18 months, tower of 6 blocks 2 years, and tower of 4 blocks by 18 months, and that's how the tower building capability will come to the future real estate kingpin called as infant.